Anita and I often joke when we go to conferences like this that she sort of presents the glass half full and I present it half empty. But I'm not a negative person. I just want to see it get to 3/4 full and I'll be happier. So I want to present a little bit on stories from the front line here. To advance, do I just click this button? Yeah. Great. So just a disclosure that I'm going to talk a little bit about CIPCO, which is the Center for Integration of Primary Care and Oral Health. And this is a collaborative agreement with HRSA, which means we work together. We don't just get money and use their money. So, so that's the statement I have to make. But it really is a collaboration between Harvard Dental School, Harvard Medical School, UMass Medical School, and a few other organizations. And what we're trying to do at CIPCO is really take a look at what is going on across America right now in primary care and oral health coming together, and then over time continue to influence that. So I'm going to give you a little bit of what we've discovered so far. So this is, again, kind of a busy slide, but if you just orient yourself to, in this case, red is good. So at the top, physician assistants are providing, the red part is greater than 9 hours of oral health to their learners. And then DO schools, you see, the red's getting smaller and it goes down and down. But gray is 7 to 9 hours, green is 4 to 6 hours. So again, physician assistants, osteopath schools, pediatric nurse practitioners, sort of leading the way, and then this trickles down. And orange is bad, and you can see that gets larger and larger when we get to internal medicine and obstetrics. So, and this was surveys of all of the different schools and residency programs, so across 13 disciplines around the country. So a huge, huge undertaking. So those are the hours, but how does that result in competence? So this is asking the program directors and the deans of their schools, are your graduates competent in oral health? And again, pediatric nurse practitioners, 51%, so a reasonable number. PA programs, around 50%, and then you can see the numbers start trickling down. So that's unfortunately the glass half empty. If we compare this to the past, the numbers have increased, but we still have a ways to go. And when we're talking about geriatric oral health, again, we sort of have to take off the pediatric nurse practitioners. We have to look at the DO schools, the medical schools, the family medicine, and those numbers are not as solid as they could and should be. This is geriatric oral health teaching, so we actually looked specifically at how you were doing that. And again, dental schools, which was included in this survey, 93% were covering geriatric oral health. Adult geriatric nurse practitioner programs, DO schools, geriatric fellowships. So all the ones you expect, we're doing a fair job, and then it starts to trickle down as we get to PA programs, family medicine, medical schools. Now, we should probably pause for a second and think about who is doing the caring of geriatric patients in this country. I was quickly looking at numbers. There's 7,000 geriatricians, and it's estimated that we need about 37,000. So that's a real shortage. So if there's 140,000 family doctors, 93,000 internal medicine generalists, about 30% of the 122,000 PAs do this work. You're getting the gist of this. We're talking, when we include nurse practitioners, et cetera, we're talking about 500,000 providers. And we've got a ways to go to make sure that they all are respecting geriatric oral health and taking that on. And we'll come back to a thought that others have had about, again, who are these geriatric patients seeing if at the moment they're not seeing dentists. So again, 111 million, 108 million, somewhere around that number, not seeing a dentist. And so, if we don't get to the medical folks, I know that a lot of this meeting so far has been about the dental aspects of this, but it's that medical person who makes that connection that makes the referral. It's the person who gets the primary prevention going. It's the person who gives the advice around the dentures. If we don't focus on that as well, then I think we'll get ourselves into trouble. And it goes back to what Dr. Isham said earlier, getting the benefit is just the beginning of this. It's got to be a team effort. I think Dr. Bergman was also just, that team effort is essential. So we're not trained well enough yet, but I do want to start to fill the glass up. I do think there is hope here. So as we're inching towards this, and I hope we're talking years and not decades, then I think, there are things that can help. So, we've done programs, as others have. Steve Geierman presented at this from the ADA at the National Oral Health Center about sort of dining with the dentist, or walking across the street, or however you want to call it, where you can cover topics that you both are interested in. And we've done this with HPV and oral cancer, with the opioid crisis, sort of working together. But it would be easy to add, geriatric themes to this. And we sometimes do it at lunchtime, we sometimes do it at the end of the day. And we've been playing around with how to evaluate this. This is a kind of a busy slide. The top half being questions we asked the physicians and nurse practitioners and PAs, and the bottom half being what we asked the dentists. And I'll just have you focus on question 5 and 6 in the top and question 1 in the bottom. So how would you rate your awareness of local dentists and the details of making referrals to them? Or how would you rate your current ability to communicate with local dentists? Or on the dental side, how much do you perceive that your medical colleagues are interested in oral health of patients? And when we looked at the numbers, you sort of started off with MDs thinking sort of, my ability to refer or to communicate 4.6, 4.2, but after they had lunch, those numbers popped up. It was a lunch. It was pretty easy. And then we went back and said, how's the referrals going? And the referrals were increasing. For the dentist, how much interest is there in oral health? 6.5. Oh, that pops up to 8.3 after lunch. These guys actually do care about this. So this is low-hanging fruit, to have lunch and chat and figure this out. At the Mass Medical Society, we have an oral health committee. We checked the other 49 states, and we're the only state that has a committee on oral health. We brought together ear, nose, and throat, oncology, OBGYN, dentists, everyone that we can think of to get in the same room every couple of months and think about how can we message the public, how can we message our own constituencies. We've done geriatric oral health messaging. We've said, what do you do when there's not a Medicare benefit? Where are you going to send your patients? How are you going to advise them? This is pretty easy things, the ED dental collaboration, et cetera, et cetera. So I think this has been one helpful area for us. The other Massachusetts message I want to bring, and this shouldn't say Oral Health Coalition, only one in the US, it should say Oral Health Caucus. I know there's lots of oral health coalitions. So I believe we're the only state with an oral health caucus. And so our coalition works with that caucus, members in the House and Senate, to get things done. And I think it's one of the reasons that Massachusetts has become one of the states that has a pretty good benefit now for adults. I mean, we just added deep root scaling and planing on April 22nd, in addition to all of the other services that are provided. Why don't we have an oral health caucus in the Senate and House of the country? I was just looking at what we have. We have a Friends of Spain caucus. We have a bike caucus. We have a community college caucus. We don't have an oral health caucus. So I decided to take a look and see how many health providers are there in the House and Senate. And right now there's around 30. It depends what numbers you look at. 17 physicians, 5 dentists, 3 nurses, 3 psychologists, an optometrist, a PA, and a pharmacist. I mean, that's the basis for an oral health coalition. And then you reach out to all the folks that were on the presentation earlier that have said they want a Medicare benefit, oral health benefit, and we could really have a coalition that would move this along. So I think I'm going to reach out to Donna Shalala after this and see what she thinks. So again, I just want to reiterate Smiles for Life. I think Anita's done a good job of summarizing it. But this geriatric oral health module is very easy. You go online, you do it online, you get credit, but if you want to download it and present it to others, you can. If you want to download it onto your smartphone and carry around the information, you can do that. If you want games, if you want cases. So we don't need to reinvent the wheel on how to educate healthcare, the sort of medical side of healthcare providers. We have the tools to do that. So the second conclusion I guess I'll leave you with is addressing senior oral health will take more than the dental benefit. I think we do have to look at the Medicaid model. I think we have to think about why aren't people getting to the dentist? Is it transportation? Is it social mores? Is it the physicians, the PAs, the NPs, et cetera, not taking it seriously enough? And we need to keep moving that along. I think we do need these creative approaches of dining with the dentist or having an oral health caucus, et cetera, to keep moving this along. And then the last thing I want to say is we haven't told too many stories here today. I've only heard one patient story, and I told this story recently at a Harvard meeting about my patient Jim, but as I thought about it, I was thinking I need to compare Jim to Marie. So 2 patients in their 30s and 40s that lost all their teeth, 2 with serious mental health issues, the medications drying out their mouths, the depression making them less motivated to brush their teeth, not getting good dental care because they're kind of seen as strange folks and they didn't always have proper insurance, etc. But Jim got a Medicaid benefit. And the Medicaid benefit in Massachusetts meant he got dentures. And so once he got his dentures, he got back to roofing again, and he had more confidence. And Jim looks really good when he comes in to see me. His depression is better than it was. He's got money in his pocket. And Jim is doing better than he was in his 30s, now in his 50s, whereas Marie is continuing to go downhill. And I can't pull her back out of that. And she doesn't have a Medicaid benefit, and she doesn't have dentures, and her weight's going up for the soft sort of junk food that she's eating. And as her depression gets worse, she gets on more medications, which dries out her mouth more, and it's been awful. And so to me, I can see those 2 patients right in front of me and see the difference between someone who can get to the dentist, who can get dentures, that can get all that, and the person who can't. And so I think we really need to think about, Diamante Driver did a lot for pediatrics. We've got tons and tons of these stories out there. I'm one provider, I'm giving you an N of 2. I could give you an N of 100 in my office and then get 100 doctors together and we'd have an N of, exponential. So I'll leave you with that. We do need to think about stories. We do need to think about, Marco's statistics. We do need to put this all together and work together, as Dr. Bergman said. So thank you.